We're here today, it's very exciting, for the Business to Business Forum. What Blue Cross has learned is our Louisiana businesses make such huge investments in the health insurance of their employees. We wanted to make sure our employers had access to the latest and greatest information on exactly how to provide those benefits and what they can do to improve their employees' health.
Excellent. So why is this important in a grander context?
Well, remember, if you have health insurance and you live in Louisiana, 90% of you get your insurance through having a job or being related to someone that has a job. So employers make huge contributions to the healthcare system, and their wellness programs are critical to helping Louisiana get healthier. We have a lot of health challenges, as you might know, in our state: obesity rates, diabetes rates, and this is one step we can take to start putting some of that aside.
Well, you know, the landscape of medicine is changing daily, and between Obamacare and Trump care, people really just don't know the answers. And we know in a few weeks there's going to be a lot of information given out because Congress is going to vote on what we need to do with subsidies and many other things. So we need to equip the business community so that they can understand what the subtle differences may be, and maybe there may be some big differences, but they need to know all the information so that they can make sure that their employees actually have the best health care, but also that the business can actually get the best bang for their buck so that they can be sustained through the healthcare changes, because we want the businesses to be around as well.
Excellent. And so what are some of the important issues that businesses should be aware of?
I think a lot of times businesses, they don't look at the stress level of their employees, and that really equates with a lot of absence from work. They are not necessarily looking at the wellness of their employees. And so once you start looking at that and start trying to get maybe some wellness programs started, then that will actually make your business healthier because your employees will be healthier. Also, I think people don't really look at the insurance that they're offering their employees. There are a lot of things that they can do to maybe streamline costs as well as increase some of the benefits, and you have to go through this stuff piece by piece to make sure that you're getting the best quality coverage and everyone is winning.
So Dr. Washington, I understand you have a recent article that's been released that's related to information technology in the industry. Can you tell us a bit about it?
Yeah, I was pleased to be able to have an article published today in the New England Journal of Medicine with the other 4 national coordinators of health IT who are working in the Obama administration. Our push was to talk about some of the progress that we had made in health IT, how it can support the better care in the country, but it was also to point to some areas of improvement, some opportunities that still exist. I think we made good progress in that period of time, particularly in the area of adoption of health IT. It lays the platform for a lot of things in the future for us, but there's still work to be done.
So how does that apply to what you're here for today?
Well, really, we believe that the foundation of improved health care is based on having good information flow. And before we had digital records, when everything was on paper, it was very difficult to do the kinds of analysis that's important for improvement, to really give transparency to businesses so they can understand how their healthcare dollars are being spent, to make businesses and members smart consumers. That was all a very important part of really setting us on the path for success here. So today when we're talking about really businesses and how they can take care of their employees and help them have happy and productive lives, the foundation of health information technology is a key part of that.
Excellent. So are there any other key parts that you think are important that businesses learn today?
Well, it's just the beginning in terms of some of our journey. And so what we want to talk about is really how this information flow can be used to support our overall goals. That's improving the health of all the citizens of Louisiana. So it really focuses not just on the actual delivery mechanics, but on some of the social determinants of health, how we take care of our environment, how we take care of the food, nutrition, and health aspects of life for the citizens of Louisiana. Blue Cross is really committed to that larger goal, and really having people have adequate coverage for care is one of the key steps. So we want to talk with businesses on how they can be smart consumers and how they can partner with Blue Cross and Blue Shield in making their members and employees just happier and healthier.
Welcome, everyone. My name's Mike Berto. I'm a healthcare economist, and I work for Blue Cross, and I'm going to be your moderator for our lunch panel. I just wanted to say it was wonderful for me to hear Dr. Merlani's presentation, because about a month ago I engaged in a similar tool for my personal use. And I'll tell you, I'm 56. I've lived in Louisiana my whole life. I'm a metabolic train wreck. That's my doctor's description, you know. Now, to be fair, for the last 12 years, I've been a very good patient as far as medication adherence goes. But as far as the diet and the lifestyle stuff, I'm like, you know, I'll just wait till I have that first cardiac incident, and then I'll change everything. Well, very seriously, back in February, I had a buddy who was 48. Picture of health. And what I didn't know about him was that he hadn't been going to the doctor or having anything checked, had heart disease in his family, had a heart attack at home, and just died. Had never had his cholesterol checked at 48. Can you imagine in this day and age? There's still men running around saying, I'm fine. Look at me. I'm the picture of health. I think sometimes we just have to play ball, right? Humble ourselves a little and listen to what the doctor says. So, when I went about a month ago and decided that it was time to make a change, we have an online diabetes prevention program that we use, and it has all the kind of tools Dr. Merlani's talking about. I have a scale that talks to an app that tells me what I'm doing. I've been at it about a month now, and I will tell you that it's been way easier than I expected. And I'm very impressed with what's happened so far. I completely cut caffeine out of my diet. Dare you to do that. Dare you. No caffeine. Diet soda, gone. Like, you know, so that's like a gallon a day of fluid I have to replace, right? No diet soda. And a small exercise routine in the morning. I'm kind of a cripple, so I can't really, you know, get and run on the treadmill. But it's been about 3 weeks, and I'm sleeping better. I feel better. I've lost about 14 pounds, which sounds impressive, but don't get too excited. I started at like 3. So, you know, I had a long way to go. So I'm a believer now. It's been almost a month. And I'm telling you, my phone beeps at me and tells me, hey, you didn't write down what you ate for lunch. And it's forcing me to be engaged in what goes into my mouth and what I do during the day, which are things I usually would rather not think about. As I like to say, it's not so much that I've battled obesity all my life, because I've been a big person for a long time. I've sort of surrendered to obesity for probably the last 30 years. And now the battle's back on. So I would encourage you, if you have friends or family who are going through this, let them get engaged. You know they carry that smartphone with them everywhere they go. Why not let it become part of the process? So I'd like to go ahead and introduce our panelists for you so you can get a sense of the subject matter experts we have put together for today. Now, the way we're going to do questions for the panel is through an app. Right? And it's online. All you have to do is open up your browser on your smartphone or on your tablet and go to www.slido.com/B2B. And there'll be a box there, slido.com-B2B. There it is on the board. And there's a box there where you can ask questions, and when you submit them, they'll show up on my iPad, and we can give them to the panel if we have time. So if you've got questions you want for the panel, start thinking about that. Let me tell you who we're dealing with. You've met Dr. Merlani, very exciting stuff that he had, but we also have Dr. Corey Hebert with us today. You might recognize as an on-air medical editor for WDSU. Here in New Orleans. He's a practicing physician, assistant professor at both LSU Health Sciences Center and at Tulane University Medical Center, and he's also a frequent guest on the Dr. Oz show, on MSNBC's Ed Show, and on the Discovery Channel's How Stuff Works show, which is one of my favorites, by the way. On the radio, you'll hear him as a host of the popular talk show on Cumulus Broadcasting Network called The Doctor for the People, and they simulcast this show on the internet as well, so you can hear it anywhere in the United States. A career-long advocate for community health and wellness initiatives all over, but particularly here in South Louisiana. Now, Dr. Hebert, you've been speaking a lot about how people don't know what they don't know. when it comes to healthcare, in the case of businesses, they really need to find out what's going on so they can make better decisions for themselves and for their employees. It can be really challenging for them to figure out what they don't know. Can you talk to us a little bit about how access to more information can help employers make that leap to what they need to know?
Sure. First of all, thank you for having me, Dr. Maloney. It was a great presentation. And I'm sure a lot of you may have heard that these types of innovative things are happening, but they may not be happening at your hospital, and you're excited now about this. It's important that you realize what you don't know, because as you saw in the presentation, there are a lot of variables that you think aren't there that are causing people to not be healthy. Number one, let's think about this. A study came out by Dr. Chaudhry out of Harvard the other day that basically showed that people, even if you remind them, do not want to take their medicine. Even if you remind them, they don't want to do it. Now, why? Why? Because they don't like to be reminded that they have a disease. They don't. A lot of people think when they have asthma, when they go to the ER and they stop smoking for a second to get their breathing treatment, they go to the ER and they sit, and then once the breathing treatment has made them not die, they realize that their asthma has been cured. And then they go away because they think their asthma has been cured. But it has not been cured. A lot of people that have chronic diseases don't really like to think about it. And what we find is that when you use these innovative tactics to make sure that people kind of have these touch points to make sure that they are getting the information, there's one thing that myself and my group have done. We have a company called Community Health TV, is that when you give the information, if the information is a talking head doctor that's speaking to you in a way that your doctor speaks to you for 15 minutes when you talk to them, it increases the engagement, but it doesn't increase the engagement as much as if you have someone who looks like you, who sounds like you, who's speaking your language when they tell you to do those things. If that is the case, then that also increases the level of engagement by about 15 to 20%. So, for example, if you have a young Italian man who is, I'm going to say young because I'm 48, so I'm going to say 47, who has hypertension, and you have a person speaking to him in a way, he's a carpenter, and you're having someone talk to him like he is a physicist about his hypertension, then that person is not going to really adhere to that because you're not speaking their language, whatever that language may be. We have social barriers, we have cultural barriers, we have lots of different barriers. And so we have a lot of new data coming out to show that people like to be spoken to where they are. Where they are. So having an O-bar, that's amazing because you can get to people where they are. I ask businesses all the time to realize that you need to be able to get to your employees, the person that is working the mailroom and the CEO. You have to be able to do that because the person that's working in the mailroom is making your business run. The person that is serving the food in the cafeteria is making your environment better. So if those people don't get the information the way that the same way, or receive the information the same way that the CEO is receiving information, then half of your business day is going to be inculcated with angry people with hypertension who feel like they've been left out. And what we found, especially I do these trainings all over the country at different hospitals, these people tend to be left out. And it makes a really bad business day. So what I'm asking folks to do and understand this very clearly. I was on a Today Show the other day, and we were talking about some new ways that people can decrease their hemoglobin A1C, blah, 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 blah. And it's really interesting because I just asked them, I said, the producers, I said, if I had a cure for cancer right now, could I tell them? And they said, no, you couldn't tell them. You'd have to say, we say Dr. Hebert has a cure for cancer, and we're going to talk about that cure for cancer next week at 6 o'clock. And they're going to tease it every day to make sure that people are going to watch. I'm in the media. And media is very important when it comes to this stuff because that's what you see. Everything is on your phone, folks. Everything is on your phone. And if you haven't invested, if your company hasn't invested in what Doctor discussed earlier, then you have to make that investment because that investment will make your business thrive. And what we want is a happy, healthy business with happy employees and sustainability for your business because we don't know what's going to happen when Congress meets in a couple of weeks. We don't know. But we got to be ready. We got to be ready.
Excellent. Excellent. Thanks, Doc. And now what I'd like to do is introduce to you our third panelist, Blue Cross and Blue Shield of Louisiana's Chief Medical Officer, Dr. Vendale Washington. Dr. Washington is a board-certified emergency medicine physician who joined Blue Cross earlier this year. He brings a wealth of experience in health IT and technology-driven clinical solutions. Before coming to Blue Cross, Dr. Washington was the National Coordinator for Healthcare Information Technology at the U.S. Department of Health and Human Services. You know, the guys where CMS is, run Medicare, Medicaid, all that stuff. He also has local roots, having been with the Franciscan Missionaries of Our Lady Health System in Baton Rouge for several years before he had the national role. And he's a lead author of a perspective article that it's being published in the New England Journal of Medicine today, actually, describing how the New England Journal of Medicine. Woo-hoo. The article describes how the free flow of data empowers better decision-making and improved health outcomes. He's having a busy week, though, because he's also featured as an alumni story in the Harvard School of Public Health magazine, which comes out this week. The article profiles his federal service and his career-long interest in health IT, a very welcome addition to the marketplace. Again, Dr. Washington, congratulations on all the articles, really outstanding. We know that health IT has expanded greatly in recent years. Why don't you tell us just a little bit, spend a little time telling us about how this has advanced the flow of information in our healthcare system and how that can lead for better results for our business clients around the state.
Thank you for that great introduction. I'll share with you something my wife said a couple of weeks ago when she found out that those articles would be published. She said, "Please, dear, enjoy your 15 minutes of fame. It'll be ending soon and you'll be back to normal." So, you know, one of the things that I talked about in that article that I'd share with you, and one of the sort of driving principles when I was in DC was this idea of changing the way that healthcare was being delivered, and we sort of titled it Delivery System Reform, and much of what Dr. Milani talked about sort of fits into the sweet spot of that. So there were really three things that we were aiming for with delivery system reform. The first is really one of the main reasons I was so excited about the opportunity to join Blue Cross Blue Shield, which is you really have to change the way that doctors and hospitals are paid in order to allow for some of the great advances in care that you've seen described before. So this idea of changing payment strategies, when I was working with HHS and CMS, we talked about really ways that we could incentivize really keeping people well as opposed to the activities that we provide, that providers do daily to sort of intervene, but sort of concentrating on wellness and concentrating on value. And obviously, you'd heard earlier from Dr. Uberhai that really part of what we're trying to do with Blue Cross is to have similar partnerships and change the way those payment schemes work. The second was really the meat of what was discussed in the keynote, which is you really have to change the way that care is delivered. So the sort of traditional 15-minute or 10-minute sort of session with your provider every 4 months to review data, to collect a little bit of information at the front of that visit is really not the way that we're going to turn the corner in terms of value being delivered in terms of patient care and keeping patients well. So this idea of sort of touching those areas, even the aspects of the social determinants, really need new ways to think about it. And then the area I was most passionate about and have been for a fair portion of my life is that for 1 and 2 to happen, you have to have a different way that technology works as the underpinning of the health information system. So in 2009, if you really look at what was going on from an information flow in healthcare, almost all of medical care was provided and documented on paper. Less than 10% of hospitals had those electronic medical records that were discussed before. Maybe a little bit less than 20% of physician offices. We made some policy interventions over that period of time and spent a little cash, somewhere around the tune of $35 billion, but who's counting? To sort of support the efforts in healthcare IT. But today, if you look across the healthcare system, almost all hospitals and about 75% of clinical offices, physician office practices have health IT. And that's the infrastructure on which some of these pivots can be made. And to the specific question, you really can't talk about really making these great interventions and stepping in and doing great things with patients unless you have digital information and that it freely flows from that one part of that system to the other. And I don't mean just among providers and payers. I also mean patients. We talk a lot about transparency. You saw some of the booths outside about some of the things that we're trying to do from the AIM Shopper, some of the care delivery models. All those things are really powered by the free flow of information. And I'm just really excited about the partnership, but also about where we are in healthcare now that we have this foundation that's laid and all the new things that are on the horizon for us.
Excellent, excellent. Thanks, Doctor. What we're going to do now is go ahead and start looking at the questions you guys have submitted through Slido. Remember, slido.com/B2B is the location for the panel where you can type in your questions. We've already got some that our moderators put up on the board for us up there, our administrator. So why don't we go ahead and take a look at those. And the first one I see says, has Blue Cross Blue Shield considered incentivizing their clients for offering wellness programs with lower premiums? So, what do you think, Doc?
Yeah. So, and I'd spoken about sort of the partnership aspects earlier. I think that what we're trying to do, and a lot of the team that is more employer-facing is trying to do, is look for ways to partner as you go forward. And so, really, I think it's a new day and a new era in that space where we recognize that it's not just one lever that gets pulled. I used to tell this story about my life as an emergency medicine physician and my dealings with third-party payers and our dealings with folks in the community at that point in time. So my entire sort of deal with an insurance company at that time was to take a sheet of paper with a number on it that I wanted to be paid and to slide that back and forth between the provider until we both got tired or the day ended, one or the other. But what we're talking about now are all kinds of different ways to incentivize both members and the way the benefits plans are done and provided, and also to do that same kind of partnership with providers to really change the incentive structure for both of those parts of the equation and players. And so I think a lot of those things that may have not been traditionally things that we've talked about are clearly on the table as we begin discussions about how to best link those three parts of the stool to help us move forward.
Excellent, excellent. Let's take a look at the next question I've got. Is Ochsner or BCBS incorporating or planning to incorporate non-invasive wearable technology to monitor blood pressure, blood sugar, pulse ox, etc.? And if so, which ones?
Well, I can speak for Ochsner. I guess it depends on what you define as a wearable. So, for instance, in the video you saw that we had a wireless blood pressure cuff. That's not technically a wearable, it's just a connected device. And so the answer is, yeah, we're already doing that. And we hope to be able to work with Blue Cross to do it again for their patients as well. So the answer is yes. But we're also expanding now to go into diabetes and COPD. Again, these are not necessarily wearable devices, but if you're using a glucometer and you're checking your blood sugar, then why can't we get that information real time as well? And we can do that. If you're using an inhaler, every time you use your rescue inhaler, we can be notified about it. Not only that, but we can know the GPS coordinates of where you are, we can see what the environment is, and we can actually, help guide you in terms of preventing recurrences down the road. So these are not technically wearables, which this might be a wearable, or Fitbit would be a wearable, but they're connected devices that we routinely use, and they can really be utilized to advance the technology that we just talked about from a health IT perspective and use that as a platform to do a better job in terms of monitoring and keeping an eye on patients as well as intervening when appropriate.
If I can make just one quick sort of follow-up comment on really this idea of the first part of delivery system reform, changing how folks are paid and how incentives are aligned. What you really don't want to do in this situation is to constrain the innovation of providers in this space. And so in some of the better designed systems, and we're certainly hoping to sort of push forward with this from a partnership perspective, what we want to do is to make sure that new innovations, new care delivery models that help advance wellness in the community are not constrained by some of the former structures that were in place. So if, again, the relationship is I pay you only for activity, you do X, I pay you for X, you do Y, I pay you for Y, it hampers some of the sort of more innovative solutions that come forward. So we're hopeful that a lot of innovations, maybe even ones that neither of us have thought about to this point, can fit into strategy as we go forward, and we can incent both providers and folks in the community to kind of innovate and to bring great new solutions to market.
I'd like to add something as well. I mean, we are all in this room sitting here as the choir, and we're preaching to you, okay? So the issue becomes the people that are outside of these doors that are really burdening the healthcare system with not paying attention to their chronic illnesses and not treating them. So with wearables and things like that, those things are very important. But how do you get the person to wear the wearable? That's the problem. Because people that are here want to do that because you want to be healthy, but there are a lot of people that don't feel that way, and so it's a bigger problem because we know what makes people change. Fear and money most of the time, right? And when you try to, you can't scare people all the time, and you can't just give them a bunch of money. So you have to be able to say, what other things can I do as an institution or as a business or as a physician or nurse practitioner to make someone want to do those things? Has anybody here seen this new documentary out called What the Health? Have you seen this? Okay, I'm glad you haven't, okay? It's on Netflix, and it is taking the country by storm because it's a documentary that basically talks about the fact that if you eat meat, you're gonna die, and that's the problem, okay? It is on it's Facebook, I mean, it's all over social media. And you don't really know about it because you're at a different place because you want to wear the wearable. This is catering to the people that really don't want to wear the wearable. So what has happened is that it's got my grandfather, who only eats meat, saw this and said, well, I'm not going to eat that anymore because it's very compelling. Compelling. The problem is that 92% of it is incorrect. All the data has been proven to be wrong, but it's compelling. And that's what we have to do with the wearable. That's what we have to do with our message. We have to make our message compelling enough so that people will want to do it. Your grandmother, I make health video all the time, and I am a little bit forceful in my message, but so was your grandmother. Your grandmother would tell you to do something and you didn't say, well, I'm not gonna do that because I don't like people yelling at me. You didn't say that. You did it because you trusted her. People trust Ochsner. They trust Blue Cross Blue Shield. They do things when they trust the delivery and the deliverer. What can you do for your business so that they trust you enough to wear your wearable? Think about that when you leave, because that will make the biggest difference in your business.
If I could make one other comment, it was when you were mentioning that, Corey, it made me think of a study. It is true. It's just a fun thing. We talked about earlier the influence of family and friends, and Corey elaborated to that. There's a study done at MIT. And it had to do with a wearable device and getting people to exercise. So they took students in dorms in the wintertime in Boston, you're not getting out much, and they gave them all basically it was a Fitbit. And they said, I'll pay you X number of dollars, like $20 at the end of the week, if you can increase your steps from where your baseline is after measuring it for a week to another, 20% more. And about 17% of the students accomplished it. They actually, got the cash, and then they said you have to stay with the Fitbit, and they went right back to where they were. So obviously, they 17% responded to the cash offer, increased their exercise, no more cash, no more change. Then they did experiment 2, and they asked each of these individuals, who's your best buddy? Who's your best friend? Your best girlfriend? Your best, friend? At school. And well, Wendell's my best buddy here because he and I, we like football together and we do stuff together. So they said, okay, and who else? Oh, Corey's my other best friend, and we hang out. So they said, okay, thanks a lot. And then they send a message to these two, my best friends, and they said, we will pay you $20 at the end of the week if you can get Milani to increase his activity. Okay.
Peer pressure.
It was 100% effective, and when the money went away, it stayed. Okay, so people like me kept on exercising because my best friends, it's almost a grandmother analogy, got me doing it. So the point is that monetary ways can have an effect, but they tend to go away typically, and what's much more powerful than money is the influence of family and friends, which we alluded to earlier. So, true story.
We used to do and still modestly doing it. There was a clinic called the Wetmore Clinic. I don't know if you guys know about it, but it was a clinic in New Orleans, and it was for TB medicine. So people that got positive TB test and they were actively having TB, we would go to the home, give the person the medicine, give them the money, watch them swallow it, and then leave. Direct observation therapy. Even that didn't work 100% of the time. It was pretty good. It was really, really good. But still, I can pay you. The medicine didn't even really have big side effects for you. And I can just watch you. I have to watch you do it. I would come to your house. So getting people inspired. Getting people inspired to change is important. And we can do it.
Excellent, thanks. I want to shift gears a little bit, and most of the interventions you guys are talking about kind of start with pharmacological intervention and move into behavior. Can each of you tell me a little bit about the groups that you deal with, the kind of stresses and pressures and changes that you're seeing based on the trend in the cost of pharmaceuticals right now and how you see it affecting us? I know at Blue Cross, for example, I started working there in 2004. About 12 cents of our premiums in 2004 bought prescription medications, and this year it's over 20%. So what is that crowding out? A lot of other stuff. I'm very interested to see how that's affecting the populations you guys deal with.
You want to start on this end?
Sure,
that one, sir?
No guts, no glory.
Oh gosh, this is really difficult. When I started practicing medicine in 19, you could write a prescription, and the patient would get the medicine. I mean, that was it. It was not that big of a deal. Now, and I deal with the pediatric population, and in New Orleans, the pediatric population is a lot of Medicaid. And the Medicaid formulary, I tell my patients that are poor all the time, it sucks to be poor. It sucks to be poor because the once-a-day treatment for the ear infection, you don't get that. You have to take the 3 times a day medicine. And what happens with adherence when you have to take a medicine 3 times? Hell, I can't even remember to do anything 3 times a day. So what happens? Then you have decreased compliance, and then you have more ear infections, and then that makes more tubes having to go into the ears, and more hearing loss, more speech therapy because of hearing loss. This is a major, major problem. We fight about it all the time because you have Medicaid fighting, saying, you know, the pharmaceutical companies are charging too much, and then you got the guy who was charging millions of dollars for the medicine, and it went up 5,000%. Then you had the whole EpiPen debacle, and so the pharmaceutical companies have a hand in this. Okay, insurance companies have to make money. They have to provide service, but they also have to make money. So that's an issue. And then you have the Medicaid issue. And the Medicare issue. So it has greatly impacted me, and I really don't know where it's going to go because we don't know what's going to happen in our country in the next couple of weeks for these votes and what kind of insurance and things we're going to have. But it is greatly impacted. I literally had a patient the other day that had allergic conjunctivitis. Eyes are watering, and had Medicaid. And I prescribed some medicine for the watery eyes, and Medicaid didn't cover it, basically. And so you just have to have watery eyes, go get some Visine, or I got to try something else. And that's it. Sucks to be poor.
So let me weigh in on this one just a little bit. So I've been practicing medicine since 1990, and I will suggest to you that there is something that is different that is going on. This is what I want to put forward. So Mike sort of referenced one of the data points that we have, and this is one of those things that's been part of my steep learning curve since joining Blue Cross Blue Shield. But one of the things that's flipped, and I'm talking since 2009, not 20 years ago, not 25 years ago, but since 2009, is a huge increase in the dollar that's spent that goes to pharmaceuticals. And so this idea of what used to be about 19 cents on the dollar, which is now 26 cents on the dollar. And if I could sit here and look at you all and say, that's primarily driven by great new specialty drugs. I mean, we have a lot of those that we can talk about. The fact that we can cure Hep C now, and some diseases that I learned about in medical school that we're taught day one, you will live with this for the rest of your life, now can be treated in 2 months, you can be disease-free. But it's not that. It's not that alone, at least. And so when we look at things in terms of a cost perspective, about probably 3 or 4 years after residency, they introduced proton pump inhibitors, which are these medications that are good for stomach ulcers. About 10 years after their introduction, you can now go into the grocery store and buy Pepcid. And right today, you can sort of buy that medication, and you can buy good old Motrin in the grocery store or CVS down the street, and that medicine will cost you about $41 for a month's supply. Drug companies now have a combination drug, a couple of combination drugs, by the way. If you put those two medicines in the same pill and give it to a person, that drug is now $2,300 a month. And that is something that is relatively new in this space. It also happens with some things like topical analgesics, medicines that are made to sort of numb the skin to do procedures. Years ago, they used to give them in like big jars or tubes, and you could find them all around the emergency department. Now, if you actually put them in a kit that a provider uses, now it's 1,000 times more for that particular topical anesthetic to be in there. So there is something new that's going on. Another factoid is today we actually spend more money for prescription drugs than we pay doctors. So the people who've gotten squeezed over that period of time are predominantly physician and physician providers. If you look at where the numbers have changed, insurance companies take about the same percentage of that dollar. Hospitals take about the same percentage of that dollar. Professional expenses are the ones where it's getting significantly squeezed over that period of time. So what has our response been? I think that there are two things that we can do and two things that are at play. So the first thing is to really talk about what it means to have your prescription given and sort of that flow through the system and get into a patient's hand. And for years, we've essentially stayed out of that space, but now we are more and more talking with employers about closed formularies. Closed formularies was a bad word at one point in time, but to be frank with you, there are too many new drugs, too many of these strategies being run without good transparency to folks on what's going on in that space. And so many times the patient nor their employer, and I'll promise you, most of the times the physician doesn't know that those activities are going on. They know that a drug rep left a package out front or someone bought lunch for the front staff, but they don't really know what the entire game is. And so we've put in some strategies that really say, for these drugs that are not value-added drugs, there's going to be a process by which that we say, look, this is probably not a value proposition, and have conversations with the doctor before that it gets executed. I think that's part of the puzzle. I'm going to share one last thought on that. So number two in that is this idea of transparency. And I think Milam Ford, which is one of the great pharmacists that's on our team at Blue Cross, is giving one of the sessions today about this. But if you talk about where this information needs to go, we try to now provide bits of intel about what's going on with your employees and their medication use when you have visits with our team, so we have some transparency. But not only there, but with physicians. And I promise you, as an emergency medicine doc, when it comes time to prescribe medications in my EMR, most of the time I don't have a clue. I have a little Walmart $4 list maybe over here, but I as a practicing physician did not have a clue. We're working very hard with partnerships and with our providers across the state so that some of that mystery is gone, and so that those electronic medical records we talked about before can help support physicians make good decisions on behalf of patients, so that both the patient copay and the overall cost of the system is more transparent to the individual. I think those are going to be two key things going forward.
Dr. Malani, go ahead.
Yeah, I'll give, just to pile on one more example. One of the oldest drugs we have is a drug for gout called colchicine. This one, it'll make all three of us start to cringe now, because this was pennies. I mean, it's been around for 30 years. I mean, it's been around forever. And somehow a drug company was able to get the patent for this, and now they're charging it like, 1,000-fold more just to get a drug that we're used to pay pennies for. It's the same drug. They just somehow bought out a patent, and now they're able to they have a monopoly on it unless somebody else comes along because nobody was, wanted to make more of a penny drug. That's an example. So it's really just gouging by a pharmaceutical house. The final example I'll give is this, and this is something different, and that is, how can we make better decisions as doctors around the transparency issue? And it's twofold in transparency. I'm going to give you an example of something we just rolled out about 2 weeks ago, and that is urinary tract infections. So if you come to see me or any of us and you're having a classic UTI, one of the things we do is a urinalysis. Yep, you got it. Here's a drug that we think is going to be effective, but it's taking your best guess. What we have, and moreover, the most common organisms that are causing that urinary tract infection differ from where we are located in this hotel, say, than if we were in Metairie or Baton Rouge or even Kenner, okay? I mean, just within the same city or just the borders of the city. So what we have in front of the physician now is the most common organism in that location in the last running 30 days. So it's updated every day, the last 30 days. Here's the most common organisms, the most effective drugs that will kill that, and going from the lowest cost to the patient up to the highest cost. So now we're not blind. We're not just taking a guess and I think I'm going to put you on Septra. I'm going to say, you know what, in where you live, the most common organism that's causing this right now in the last 30 days is this, and the cheapest for you will be that, and that's what I'm giving you. And so we can not only give you the chance to hit it right without guessing, but also the lowest cost possible. That's the kind of way that information and transparency could help us reduce drug costs.
Very good. Thank you. We got time for one more question, and there were several in the queue about workplace wellness program. If you were managing a workplace wellness program, what's the first thing you would do, the second and the third? And just take your time and think about the way that you would want to advise our clients here on the best way to structure those programs. You want to start down there, Doc? I see you smiling at me. Yeah. I can't imagine you have any thoughts on that.
Imagine that. Yeah. One thing I like to say.
Just 3 bullets.
Yeah,
bang,
3 bullets.
bang, bang.
I was at Blue Cross Blue Shield not too long ago, and I did a lecture. And when I finished, I was talking about food and what you should eat, and everybody got up and all went to some place right after I finished. And I didn't know where they left to go to, but it was, I was done, so it was all good. And then as I was walking out, I saw all of them in the workplace health club or wherever it is on the first floor in the building. They all left and they were so upset about what I said. They're going to go work this off right now. Right now. They all were there. And I was impressed by that, because I think one of the first things that I'd like to see with the workplace wellness program is you got to have something on site. It's very difficult to do that. It's a very big cost, I understand. But you need to have something on site. And you need to have wellness video available all the time, on demand, for the patients and the employees on an app. Wellness video on everything that gets to them where they are. So, what do you do if you have a burn? That needs to be an Ochsner or a Blue Cross Blue Shield doctor saying, what do you do when you have a burn, so that when they're wherever they are, they can get that information. And that also would be great for wellness things like, obviously how to eat and decrease carbs and blah, blah, blah. And the third thing I think that I would like to do is to incentivize, definitely incentivize, and not just give money, but to give extra stress days off. Stress days off, because people don't realize now that you are much more stressed out than you were 30 years ago. Because when I used to leave work, I would leave and I didn't have a smartphone, which means nobody could get in contact with me if I was on vacation. You just couldn't. Now I'm on vacation, I'm answering more emails on vacation than I am, than I'm when I'm at work. So that means that you have a level of stress that people didn't have 30 years ago, but nobody's addressing that. So you have to put those stress days theoretically right in the middle of your vacation, which that's not really fair. So incentivize the folks to get an extra stress day per month, so that they can just say, you know what, I don't have to lie about being sick, sir. I don't have to do anything. I'm taking this day off because I just need to be off today. And that's my stress day.
Excellent. Thanks. Dr. Malani, what do you think?
Well, we've done some work in this area, I agree totally with Corey that the best programs that we've seen in terms of outcomes are they have something on site. You need to have some form of on-site education. Lunch and learns and things like that often work. But at the end of the day, what we're trying to do is create behavior change, and there's a science to this. This is not something you just randomly do and then people will just do it. I mean, there's the true science. I can tell you, even like in terms of, even if you're trying to get people to eat right, the food order plays a role. I can show you the data on that. I mean, it's funny. I mean, even if we go to a restaurant, do you know there's what's called the position of, what is it called? The key position in terms of food. It'll either be the first or the last thing that the waitress or waiter will say in the list of items on the menu. If you're going through a cafeteria, it'll be the middle one in a choice of 3, or the first one in a choice beyond 3 that people will pick. It's just incredible. I mean, you can actually change we can even change how you describe the food, and we can get people to eat that food with the same food. I mean, my point is people respond to a real science of behavior change. And the key really is to get champions and to get people within the community of the workforce to want to do things. And those people can affect other people. So what we found to be very successful is you get the innovators, the group of people that are the ones that are most likely to want to do this, that are employees, and you get them to be on your team. And you say, okay, here's what we want to try and promote, and we're going to promote for the next 3 months of this, smoking cessation, or increasing our activities, or these kind of things. And they can help champion some of those efforts among all the other workers, as opposed to me trying to get it to them. They're more likely to respond to their friends and family, as we talked about. So there's a real science. The point is that there's a science of this. It's not just something you just can throw out there and expect to get effective change. But I totally agree with Corey in that these needs to be on-site. These kind of programs that are off-site often don't work quite as well as those that if you can do them on-site, if it's possible if your size of your company is big enough to handle that. If not, then obviously you can work with other companies. And then things like even competitions, where you can set up competitions within your workforce or against other companies. Just like the Saints are going to play the Falcons, we get all riled up. It's fun to say, well, we're going to be in competition with this group. We're the SEC, and we're going to go beat up on the ACC and that kind of stuff. Yes, and that really does motivate people to want to go do stuff and gives them something exciting to talk about. So we look for things like that to do too.
So food positioning is important, right?
Believe it or not, it actually is. It plays an enormous role. I mean, just simple things like that, you can have an enormous effect on the workforce, and it changes absenteeism, presenteeism, all those kind of things that are important for you as an employer.
So I guess dessert first is going to go by the wayside on this deal.
It's up to you.
I'm going to give you the last word, Doc.
Thank you.
Go ahead.
I think Corey and Richard made great points. I'm just going to focus on, say, maybe 3 things. I think the first is that, and I've had the privilege of being the executive in charge of wellness both on the provider side as part of an employer that had 12,000 employees in the state, and now with the payer side of this. So the first I'd say is your program needs to be comprehensive. And so often in situations, whether you're sort of doing this from a consultant or from another perspective, people don't look at the entirety of it. So it's not just if I have a great point system for getting my physical done and sort of walking a certain amount. It really has to, the healthy lifestyle has to be an easy thing. The anecdote I'll tell is that in one of those lives, I won't tell you which one, the sacred cow was the fried chicken Friday. Sure. And so it did not die. We moved everything else out. We had salad as a choice, but we still kept the fryers in the cafeteria. So if you want people to sort of pick healthy lifestyles, and you want that to be part of your scenario, just as this idea of having a workout area in your workplace is important, the easy choice has to be the healthy choice. The second one really is about being bold and committed. So that's sort of taking the wrath of making the pivot from, the boudin and etouffee to the sort of more healthy choices. You're going to have to make that choice and stick to it. And then the last thing I'll put on the table is I think that from a corporate perspective, a lot of the work that we do on that side is sort of quarter to quarter or an annual kind of thing. But a lot of the international companies in particular talk about sort of the stretch that's really returned these 3-to-1 and 4-to-1 return on investments for the wellness programs. They are years in the making. So there's some patience that's required because we are talking about cultural changes within workplaces. So those would be my 3.
That's excellent. Thanks so much to everybody on the panel for coming out today.
Knowledge is power. You need to get the information so that you can make really good choices for your employees and your business. We want the businesses to be around. We want the employees to be healthy. A lot of people think that those two things can't really coexist, that the employees are sucking a business dry because of their insurance payments and things like that. But in reality is that we have to make sure that everyone is healthy. The business is healthy as well as the employee, because that will make a cohesive unit to the business and the employee. The employees will have a team that will make the business better, which is better for everyone.
I think one of the main efforts that we want to put forward is that we're here to be partners with our business community, that we consider our clients not just the members, but the businesses and the community on a larger scale. For us to really achieve our mission statement of improving the health and lives of Louisianans, it takes more of a partnership approach. And so I would love for business folks to come to us with problems that need to be solved, for us to sort of approach this from a collaborative perspective. And just as an addition, I think we're also looking at that kind of effort from the providers in the community as well. I think the partnership and collaboration is the one message I want people to take away from this session today.
I really want them to remember three things. Number one, remember that the latest and greatest data is available and that we're ready to share. Even predictive modeling is available, so we can start letting people know when they're more likely to be hospitalized. The second thing is, I want them to recognize that Blue Cross is a serious partner to business in Louisiana and that we value everything they do. And the third thing is, I want them to come out and relax and be in an environment of people who are teaching them how to do a better job and feeding them lunch.